The next section is going to be discussion on cardiac transplantation. Okay. Unfortunately, we don't have any sites that do cardiac transplantation, so this is more for you know a little of the basics. Okay. This whole area has whole books just dedicated to cardiac transplantation. So this is more for you to know what you can encounter and what you possibly encounter on your board examinations. Okay. Heart transplants may be recommended for patients that are in active congestive heart failure. It's the most common reason in the United States for why they do it. Usually from severely advanced coronary artery disease. It could be also from patients who've developed a viral cardiomyopathy or any kind of cardiomyopathy, the heart's beginning to fail. It could also be to severe heart valve disease, which has then progressed to causing heart failure. It could be from severe congenital heart diseases or life-threatening abnormal heart rhythms that do not respond to other therapies. This last one is almost never now, okay? Simply because we have so many potent antiarrhythmics and so many other capabilities that we didn't have in the past. These patients will come back into the operating room and be all considered high risk for aspiration. A low cardiac output state puts them into a decreased peristalsis of the stomach. So as a consequence, they have a very high risk for aspirating on you on induction. The reason that's so important for you to know is even if the patient's been NPO adequately, you have to treat them as rapid sequence. If you have an aspiration on induction, the case is done and the guy can't get his heart transplant. So that's not a good sign. And the mortality rate from an aspiration, depending on how severe it is, can be very, very high in these patients, as much as 70%. So this is not something you want to get into. Okay? This is sometimes LVADs. This is a BiVAD where you're actually having a bilateral assist devices that are being placed in the patient. These can either be, either for end stage where they don't do anything else beyond this, which is what was the name of it? I forgot the name. Destination therapy, which means your next destination is the afterlife. Or this is a bridge. A lot of times most people use this as a bridge, giving you time to get transplanted. If we don't use these kind of devices, what you're left with is somebody that is so sick, by the time you take them to the operating room, they can almost die on induction on you. And we used to do it that way. That was really difficult. Having the assist devices in place, though, helps quite a bit, and most patients seem to do better. Now, there's all sorts of different kinds of assist devices that are available. The new ones that we're using are centrifugal pumps. The reason those are so nice is because they don't have so many mechanical parts that break down. They're very simple devices to use. Instead of this is actually a pneumatic device where you actually put pneumatic pressure and it pushes the valve down and helps push the blood around. Okay? The downside to that is if this membrane ruptures, you can get an air embolization into the patient, which is deadly. If you have the membrane either this tube kinks or something like that, then output stops. So it's got a lot of problems. The centrifugal pumps are a lot better, and that's where most systems are going towards. Heart transplant surgery is not recommended for patients who have kidney, liver disease, although that's been, now they're doing dual transplants, they're doing heart-lung transplants. So that's not so much, this is an older recommendation. If you're doing an isolated heart transplant for somebody who has other heart and lung disease as well, it's not such a good idea. Insulin-dependent diabetes only gets worse with transplantation because of the high-dose steroids. So most people go out of control, and that's one of the reasons that they were trying to go away from this. There's still a lot of people that get transplanted that are diabetics. The reason we're able to do that now is because now we have these pump devices that can give you continuous insulin, so you then don't have as many people that are completely out of control in their sugars. If you have other kinds of vascular disease, when you give immunosuppressants to them, these vascular diseases progress very rapidly. Okay? Specifically, don't ever give a transplant patient who's had malignancy, especially active malignancy. It's only going to make the malignancy get worse, and it's going to go metastatic pretty quickly because of the immunosuppression that you're doing. Okay? Again, I've seen a lot of people get transplanted that had alcohol abuse, and they stop supposedly, and then you do evaluation on them and give them a chance, and unfortunately some of them will continue to go back to drinking after they've got their new heart. Anesthetic concerns, it's high risk for bleeding post-op. Okay? That's really your highest risk. The anesthetics themselves, most of them are pretty safe, especially the heart anesthetics that we were giving. The thing is, the problem is these are very sick patients. You want to medically optimize them, and they also have very high risk for infection. This is the first transplanted heart. Okay, this is by Bernard. Okay, Bernard actually had to go back to South Africa to do the first heart transplant, although he was in the United States where he got trained to do this stuff. Okay, they wouldn't let, the FDA wouldn't allow anybody to do a transplant. So he went back to his home country and actually did the heart transplant there. Okay? So that was actually the very first effective heart transplantation done. Preoperatively, strict sterile technique. Okay, requires reverse isolation, which means that you're putting the patient at more risk by exposing him to your germs than he is causing you at risk. Okay, that doesn't mean that there's zero risk. It just means that you're more likely to kill the patient than he is to do you harm most of the time. Some of these patients have hepatitis C, especially for the, not so much the heart transplant, for the liver transplants. A high percentage of them have hep C or hep B, so be careful with that as well. But the heart transplantation, though, you got to be very, very strict about putting in all your IVs. We used to do betadine preps. Now that the recommendation is 2% chlorhexidine preps before you put the IV in. Even a small little peripheral IV can kill these patients afterwards because they're so immunosuppressed. Okay? So you got to really, everything you do has to be very, very clean, and you have to do all the reverse isolation procedures. You should always wear a mask and a hat anytime you put an IV in these patients, and you should actually go on to wearing a mask, gown, and gloves when you're doing a central line or an AD line in these patients. Preoperative antibiotics is based on the protocols. A lot of this is all protocol driven. The way I would recommend you do that is get the protocol ahead of time. If you go to a transplant center, review it, okay? Then take the sheet and put it inside a plastic sheath. That's what we used to do it, okay? And the plastic sheath, you have a grease pencil. Every time you're finished with that, you would just mark it off. So by the time you're finished, you would actually have a grease pencil mark on every single thing that had to be done. That way you wouldn't lose track of everything. Because there's so many things you're supposed to do as the anesthesia person. You have to give the immunosuppressants, you've got to give the antibiotic in the right sequence, you've got to get the high-dose steroids up front. So you've got to get this all down in the right sequence. So having that as a protocol already at hand, ready available, and especially, of course, these always happen not at 1 o'clock in the afternoon or 11 o'clock in the morning. These happen always at 2 o'clock in the morning when you're exhausted, okay? Because the transplant team has gone out to get the organ at around 6 o'clock at night. Okay, so they'll be back about 11 o'clock from their helicopters, and off we go to the operating room. Okay, so this is not the time when you want to be. You're kind of tired. You want to sort of have that set up ahead of time so you're not having to do things out of sequence. Okay, careful with pre-medication. The biggest problem with these people, the reason they're having heart transplants, is they have low cardiac output states. I've seen a lot of people get in trouble with this. Is they give 2 milligrams of Versed to the patient, and the patient is completely awake, looking at you like, that's nice, what do you give me? Okay? So because you're impatient, because you're being rushed, you got to go, we got to go back, you'll give another 2 milligrams. What you haven't realized is that the cardiac output state's around maybe 10%, and that drug that you first gave hasn't even reached the heart yet, 3 minutes later. Okay, it's still sitting in the arm vein. Okay, so when you give that other second dose, now you're going to get 4 milligrams, which the guy only needed 2. So you can actually induce complete apnea once you got the person draped out with all the lines in place. And that's when you get in trouble. Okay, so be careful. Give your pre-medications early and wait. They're all full stomachs, and you've got to make sure that your blood available is going to be CMV free. Okay? Now the way we actually extract the heart out is that they extract it by removing it off the atriums. That's where the attachment point is to the thoracic wall. Okay, the atriums are then re-sewn on to the new transplanted patient. Okay, in the old days, they used to cut away a bigger wedge and lose the SA node. Okay, so they would lose the SA node from the transplanted heart. So when you got that new heart put into you, it had no SA node, and the heart rate would be very, very slow. The new way of doing it is they actually cut away closer, and usually they're able to recover with the heart the SA node. So heart rate tends to be better nowadays than it used to be. Okay? It makes it more difficult for the surgeon to sew it in, by the way. Okay? But it saves you from having to give a lot of medications to try to reverse the effect of the low heart rate. Induction is basically a rapid sequence. Okay? These people should be considered a full stomach. Okay? All the lines should be done aseptically. Please don't put in a PA catheter. I had a heart transplant surgeon one time in the middle of the case to one of my friends. He took out the heart, of course, and then he handed over the little yellow catheter over the screen. He said, "This is yours." And that was a PA catheter. They cut it. Okay, so when you put the PA catheter in, you got to make sure it's only at 20 centimeters. You can't have it down into the heart itself, because when they cut out the old heart, and they're going to cut the PA catheter with it. So don't do that. You lose a lot of points for that. It was funny though. His eye laughed. Okay. Do a rapid sequence, or what's called a modified. Modified means you're doing a cricoid pressure and you're giving high doses of muscle relaxation, neuromuscular blockers, competitive such as becuronium or pavilon. I don't like doing it that way because you're still having a delayed time. It takes you still around 2 minutes for the medication to upload. Instead, I'd rather give succinylcholine and be there in about 30 seconds. The other thing is, because the cardiac output stays so damn low, it could be as much as 6 to 8 minutes before the muscle relaxant really kicks in. So what's the point? Just give succinylcholine. Okay? The drugs to use in this case is etomidate, is what's most of the time used because it's a rapid induction. Okay? Narcotics can also be used, but be very, very careful. These people are pretty depleted, and they have some degree of sympathetic tone still left. So adding that extra narcotic can really push them over the edge. Non-depolarizers, of course, are something you're going to end up using after the succinylcholine has worked. Okay? And basically, you follow your local transplant protocol. Maintenance is basically like a normal cardiac anesthetic. You can either go to high-dose fentanyl, benzodiazepines at that point if you want to, or you can go with gas. Most of us will go to isoflurane, at least initially, because we can titrate that off. Okay? These bypass runs are double the normal bypass runs. That's not surprising. You have to reimplant the whole heart. The other thing that you have to have in the older days was to have isoproterenol around. Isoproterenol is a selective beta-1 agent to increase heart rate, but because we didn't have the SA node in there as we do now. Isoproterenol is really going away from use because of the new transplantation methods. You may also need to use a pacemaker. The pacemaker wire should almost invariably be put in most of these patients, because in case you do get into arrhythmia, you might as well have something electronically that helps push the heart electrically. This is what a transplant team looks like. It's a lot of people. This is what makes it so expensive. Okay, there's 2 teams. One team went to harvest a heart. Okay, those people would usually fly out in a helicopter. And when they reach that destination, they go in there and do a sternotomy and remove all the organs that they need for the transplantation. Sometimes these organs are sent to many different centers, so this transplant team is responsible for the quality of the organ removal. Okay, so they'll try to remove the liver, they'll try to remove kidneys if they need to, remove the heart, remove the lung. And very quickly, all these organs are dissipated to different parts of the country. Usually it's regional. Because you have only so much flight time you can have before the organ starts going bad. Okay. Once the organ arrives at the site, it'll be taken out of a cooler. Okay. Usually it's covered in ice. Once they'll clean up the organ, reperfuse it, they'll clean out the coronaries, and then they will proceed to carry it over to the heart surgeon. Do not talk to the team when they're doing that. Okay, I saw one time where the nurse who was carrying the heart turned around, and somebody asked the nurse a direct question, and she turned her head to talk, and she tripped over one of the Mayo stands, and the heart ended up on the floor. Okay, it ended up being like the 3-second rule. They picked it up real quick. You have no other choice. Okay. And washed it off with antibiotics, cleaned it up, and then put it in the person's heart. Yeah, but this is really a bad day. You don't want to do that, okay? Okay? And what was amazing is the patient did fine, so maybe the 3-second rule does apply. Okay, so don't talk to the nurse when she's carrying the heart. Okay, it's the football. Leave the football be. Okay, okay. If you don't transplant the heart, the patient would have died. The other heart was already out. Okay. This is what's called denervated heart function. Okay, you can see how in this older procedure they've actually left the actual SA node from the other patient has left in the donor's chest still. So when you reimplant this heart, you don't have a direct connection between the SA node, which is usually up here, going down towards the atrium. So you get severe bradycardias. Pretty much the heart is excluded from all autonomic controls. It has no autonomics. There's no way to connect up the nerves. Okay, so with the new method of doing it is by taking the SA node. You can see how much bigger a procedure it is. See how they cut everything away. And then they reattach it that way. And now they've got the whole atrium intact. So this gives you a much better SA node capability, and you tend to get a lot less bradycardia with it. Okay? This still is denervated in the sense there's no autonomic control, but the chemical autonomics are still there. Epinephrine and norepinephrine will still work. That's why sopranolol will still work too. Okay? But the actual patient's electrical activity, let's say the guy after transplants, he wants to go running, and normally the heart rate will increase because you're thinking that you're going to go running. He doesn't have that. Okay? His heart rate does not increase based on stress unless the adrenal secretes an epinephrine, and then that would make the heart rate increase. Okay? So only direct-acting agents really work. Okay? All the indirect-acting agents, like ephedrine, are really not very effective in these people. Emergence is transport the patient ICU intubated. There's absolutely no reason to extubate somebody in fast track for open heart, because the biggest complication you get post-op is bleeding. So why put yourself in that position? It's nothing worse than having somebody who did a fast track on, extubate them, and then you get called back, hey, you've got to go back to the operating room, you've got to intubate a patient who's hypotensive, blood pressure 70, and still at high risk for aspiration. Not the thing to do. Okay, so don't do that to yourself. Complications following cardiac transplantation are basically three things. You can have cardiac complications. Bleeding by far is number one. You can also get infectious processes taking place. You can get rejection. That's always a bad sign. And non-cardiac and non-infectious complications. Cardiac complications are ventricular dysfunction, which could be an immunologically mediated dysfunction from the person not being adequately matched properly. That happens very, very, very rarely now, thank goodness. You will, though, over time, even though you're suppressing the immune system pretty heavily, you're not completely immunosuppress the person 100%. If you did that, any kind of cold or virus or anything that would be exposed to that patient, they would die. So you want to keep it down to a smolder. Okay? It's still got a little bit of damage taking place all the time. So what you get over time, after years, is that you get end-stage damage to the new heart because the immune system will try to kill it. Okay? It thinks that it's a foreign object. So it's the job of the immune system at that point is to try to destroy it. Okay? One of the things that you will get will be things like allograft rejection. Okay? You'll get allograft coronary disease where the actual blood vessel, because it's constantly being exposed to the immune system of the body, will be damaged earlier. Okay? And one of the things that you'll get as a consequence of that is, of course, decreased exercise tolerance. Infections can be anything. Anything you could possibly imagine will happen. Okay? Our ID guys were experts. Okay? The reason HIV was picked up so quickly in this country in comparison to the rest of the world was because in this country we were actually doing transplantation. And we were seeing the effects of immunosuppressing people, and we learned that certain disease processes were due to immunosuppression. And patients that were having HIV were getting the same diseases. So back in the 80s when I was becoming a doctor then, okay, it was really not known what was causing HIV. We did know at that point that, that something was immunosuppressing the patients so severely that they were becoming like transplant patients. Okay, had we not had transplantation, we would have had a harder time figuring out how to deal with HIV. It also has parasitic components. If the patient already has a parasite on board, they can get parasites from animals as well. So, want to make sure that they're not their dogs and all their animals are well taken care of, because the dogs can actually transmit diseases that normally would not happen to the patient. Bacterial and fungal infections can also take place. Non-cardiac, non-infectious complications are due to either the medications or due to long-term low cardiac output states. So some of these people will develop renal insufficiency. Hypertension is actually fairly common, especially with cyclosporin. You can have what's called a cyclosporin-induced hypertension. Osteoporosis is another thing that immunosuppression will also do, so there's increased risk of fractures in these people, especially if you're transplanting a small woman. Okay? Women have a smaller bone mass and as a consequence have a higher risk. Hyperlipidemia may also occur as well, and there's, of course, increased incidence of malignancy. Some people actually don't do very well when they get to transplant. They feel guilty about it, so they have psychological problems as well. Other people have glucose intolerance problems, such as diabetics. They tend to be more fragile after transplantation. And obesity may become a very big issue with all the corticosteroids that are being given. One of the things that you want to do is to identify if you're having rejection is you have to do cardiac catheterization. This is tough on these patients. I had one patient in 30 days had 80, what was it? Something ridiculous. It was 80 biopsies done in 30 days. So we were doing almost every other day, these 4 or 5 biopsies every other day. So, and it was really important for that person because they were showing so much degree of rejection. They couldn't figure out why it wasn't working. So they changed all this therapy and eventually got the rejection under control. But I was surprised there was any heart left at that point. Okay? But they take little pieces and they're not very big, and they take it inside the heart. The types of allograft rejection you can have is hyperacute. That's deadly. Hyperacute means that the organ actually turns black right in front of you. I've seen that happen only once. Hope it never happens again. The good thing was just a renal transplant. The surgeon had the renal transplant put in. We don't put renal transplants. When we do the renal transplants, they don't go inside the abdomen. They actually are right outside. Okay, they're underneath the skin, underneath the muscle layer, but in between the peritoneum, and then they attach it to your femoral artery or your part of your iliac artery. Okay, so it's up higher, so it's somewhere you can get hold of. And as soon as the blood flow got to the kidney turned black. My blood pressure, the patient's blood pressure went from 130 down to 30, like that. Started trying to die on me from acute rejection phenomena. So hyperacute is a catastrophic event. What saved the patient's life really quick was the surgeon cut away the transplanted organ immediately. He cross-clamped it, and then I was able to resuscitate him and get him back. Okay? But that's considered a hyperacute rejection. What they found out was that this guy had done was that he didn't want to get stuck anymore. Okay? And somehow his wife had given her blood instead of his. I don't know how the heck that happened, but that's what I was told later on. So they had actually allografted her to her, not to him. So not something you want to do. Okay? It's kind of stupid. I think they ended up working in the hospital or something. They were techs or something. They didn't understand the whole phenomenon. But somehow they are actually able to switch their blood. Not something you want to do. Acute tends to happen in the next first 30 days. That happens pretty frequently. And this one you have to do the biopsies to figure out what's going on and what do you need to do about it. It's a whole science of doing that. And then chronic is the ones that you're going to have that effect no matter what. Eventually it causes cellular damage and vascular damage is the most common. Diagnosis is by endomyocardial biopsy. Yes, somebody had a question? Hyperacute happens right in the operating room. Acute is in the first 30 days. Diagnosis is endomyocardial biopsies, of course, and non-invasive are really pretty much useless. Really, if you're looking for the rejection, you need to do the biopsies. The allograft coronary artery disease is something that occurs as a leading cause of death in greater than 1 year after transplantation. What basically happens is that the actual blood vessels begin to be attacked by the immune system and they literally begin to disappear. This is the same thing that you would have when you try to do hepatic allograft or a pulmonary allograft or the kidney. That's considered chronic rejection. Or you get vanishing bile ducts, or what's called bronchiolitis obliterans in pulmonary allografts. The actual immune system is killing off the blood vessels, to those organs. And as a consequence, you get these disease processes associated with them. Prevalence of disease is detectable disease in 1 year is 10 to 20%. So when you do a transplant on somebody, you're not going to give them 20 years of good life. What you're doing is you're bridging them to give them good 10 years. Okay? So it's not like you're curing the disease. You're just giving them time. Okay? Time is always good. Okay? It's better than being dead. 1 year, you have a 10 to 20% chance, and at 5 years, you're almost at 50%. So these people are now developing advanced atherosclerotic coronary artery disease, or it seems to be like that, so they need to be watched very carefully. The reason this is important is because in little old Naples, we get a lot of transplant patients. Okay? We have a lot of people that have had transplants and they then retire and live here, and we have to take care of them in the operating room, and you got to know the risk factors. If you have somebody that's over 5 years after transplant, then they have high risk factors for having advanced atherosclerotic coronary artery disease, or appears to be, but it could be it's just allograft rejection. Okay. Potential risk factors are non-transplant specific, or age, of course, sex, family history. This is the same risk factors that we just talked about, right? For ischemic coronary artery disease, same thing. Okay. Transplant specific is HLA mismatch and DR locus mismatch. The immunosuppressant drugs, of course, are continued for the rest of their life for the individual. What happens over time is that they're given certain kinds of immunosuppressants that are decreased over time, and most people begin to tolerate it better. If you have, the other thing that's concerning is if you have CMV infections. About 30% of the population has CMV positive, okay? Cytomegalovirus is what CMV is. Okay, it's a form of virus that's very common for people to be infected with it, and if you give that person who doesn't have a history of exposure to it in their blood, then you can give them a very severe CMV virus infection and make them go blind, including affect the brain. So you want to avoid CMV positive blood in these people. The donor age, of course, is extremely important. If you can get a 20-year-old's heart, it's better than getting a 50-year-old's heart. Okay? Women also have more risk than men, okay? Because women have smaller blood vessels than men. A lot of times we actually will transplant a male's heart into a female's heart, and it works just fine. Okay? It actually has a little bit better survivability than putting a female's heart into another, female, because the blood vessels in that female donor heart is smaller, so it's more likely to have problems over long term. The good thing is that most donors are not women; they're mostly males. Okay. Symptoms that you get over time when you get this obliteration of the blood vessels is angina, of course. You can actually have an acute MI and sudden death. Sometimes they're asymptomatic. You need to do a coronary angiography. You do your thallium stress test, your dobutamine stress test, or intravascular ultrasound. Now, the infectious complications can be pretty nasty. Okay? The early ones tend to be in the first month, in the first 30 days. These are nosocomial phase, which is usually wound-related or catheter-related. So it's a lot of times it's associated with what we've done in the operating room. So you want to make sure that you stay away from these problems as much as possible. The middle is when the patient goes home, usually about 2 to 5 months down the road. The patient now has been exposed to his family, who are now hugging him and being around, or he's got a 5-year-old kid who goes to grade school and he comes back, coughs all over him, he's got toxo or something bad, and now he's got exposure to it. Okay? The weirdest one I ever saw was a patient who was very big into plants, and he was working on his roses. And roses apparently, which I didn't know at the time, have very high concentrations of nocardia. Okay, nocardia is a kind of it's not really a fungus, it's more like I don't really know exactly what it is, but it's very invasive organism, and it basically takes away your skin. Okay, it's like a little hyphae goes in all over the tissues. And the way we actually kept him alive was we had to remove at least about 1.5 feet of skin off his arm. And we almost had to do an amputation on his arm, but he got it back. So nocardia has to be directly removed clinically, so if you get it on your face or something like that, it's devastating. Pneumocystis carinii can also occur. That's the same thing that we would get with what? HIV. Okay, so that's where I was telling you that before. you can get bacterial infections like this, and of course the person is not going to do very well in comparison to a normal person. Malignancy is also incidences 1 to 2% per year. Cutaneous malignancies are by far the most common, which is squamous cell carcinoma and basal cell carcinoma being very common. The other thing that gets activated is lymphoma. Okay? The most common tumor in cyclosporin-induced immunosuppression is lymphoma. Okay? So CYA, which is cyclosporin, actually may induce lymphoma formation. And the question is why? And the reason being is because the immunosuppression that it affects more the immunosuppressive side of it that's controlling viruses. Okay, lymphoma is thought to be caused by what's called the Epstein-Barr virus. Okay, Epstein-Barr virus can be put into a quiescent mode when your immune system is adequate and you don't develop lymphoma. It's when you become immunosuppressed that the Epstein-Barr virus gets loose, and then it causes lymphoma to develop as a consequence. So that's why we think cyclosporin causes that. And the most common location is not usually the peripheral where you tend to feel it, but they get intra-abdominal lymphoma. Okay? And it's a little bit more difficult to diagnose. You have to do the CTs, serial CTs, to keep an eye on these people. Okay? Most of the time, the first sign that the person has a lymphoma is they'll develop digestive problems. They'll feel that they're full and they can't really eat very well. The lymph nodes are actually enlarged and compressing on the retroperitoneum, and it will actually disrupt your GI tract system to a certain degree. Treatment, of course, for any kind of cancers is reduce your immunosuppression, reduce your acyclovir. You may have to treat them with chemotherapy and radiation. Of course, these risks, of course, go right to the roof because a lot of the chemotherapy agents will actually damage the new heart. So not something you want to do too much. Cyclosporin can also induce nephrotoxicity. It's a major decline in renal function in the first 6 months. And they get a disproportionate azotemia, which means they start losing protein. They may also develop hyperkalemia, increased uric acid levels, and a mild proteinuria. And they get a decreased fractional excretion of sodium. The reason we think it is because cyclosporin tends to affect the afferent arterioles more so and causes than the vasoconstrict. So your GFR rate begins to drop off. Prostaglandins seem to be slightly inhibited as well by cyclosporin. And you get direct effects on the smooth muscle, and you get direct tubular toxicity associated with it. A lot of times cyclosporin will eventually end up leading to hypertension because of the system is not receiving adequate blood flow, so the blood pressure starts to rise. So you get cyclosporin-induced hypertensive syndrome. The incidence is 50 to 90% of cardiac transplant recipients, so you can see cyclosporin has a really high incidence of hypertension. It can occur up to weeks to months afterwards, and the treatment goal is really to maintain a blood pressure around 140 over 90 or less. Maintain or limit your salt intake, monitor for ideal body weight, moderate exercise. A lot of times they add ACE inhibitors or calcium channel blockers and diuretics. Okay? You got to be careful with it and don't dry this person out too much because then they can put them in renal failure. The other thing that occurs too is the last two slides is hypercholesteremia. Cyclosporin can also do that, as well as cumulative doses of corticosteroids increases your lipid content. Okay? And what ends up happening is you end up getting a lot of increase in weight, and also may cause some other associated problems, including advanced atherosclerotic coronary artery disease, out of step with what the age of the patient is. And the last risk factor is osteoporosis, which is unfortunately what we see here is that a person will come in with a liver transplant or a heart transplant and they have a fractured leg. And the reason they have the fractured leg is because of the osteoporosis, and you have to take care of them. Okay? The other risk factors is that low cardiac output states also depletes your calcium over time. So the person was waiting a long time for their transplant. It already puts them into a depleted state already. And of course, these other drugs are making the situation worse. Prolonged loop diuretics can also cause bone loss. Okay? Cardiac cachexia, which is, again, part of what I was telling you before, and postmenopausal status as well. So women are at most highest risk for this. Okay? And that's it.